This cumulative across a variety of agencies, we're looking at a reduction of $276 million. This is really programmatically a deeper reduction because some programs in state agencies have numbers of participants are growing. Simply they are eligible. There's more of them. For example, in senior programs, older people, we have more older people, and so those costs go up. We've pushed those costs back down, and we've reduced the overall by $276 million. In health, in the area of health, we have a $325 million set of program reductions. Let me just give an example. In the prescription drug assistance, we have a program that supplements Medicare Part D, which is prescription drug assistance from the federal government. Because they left a donut hole, and it's not a complete program, the state has been assisting elderly folks with their, poor elderly folks with their prescription drugs. We're going to have to cut that back by about half, saving $70 million. We're looking at a policy to require greater cost sharing from retirees for the group health insurance, and beginning our program of managed care, a pilot program for seniors and adults with disabilities. Let me move quickly to...
What's the impact of cutting that prescription drug in half? Are you cutting that in half the number of people, or are you cutting in half what they...
The benefit.
Do you know what the average is now, or anything like that?
I don't have that detail. We'll try and get that to you. I wanted to move on and talk for just a minute about performance metrics. This is a concept that we've had some progress with over the last number of years, but in the final budget last spring, the legislature adopted a performance metrics to apply to all state agencies, and so Director Vaught has worked with all the state agencies to identify performance metrics. How do we know that the program is achieving the outcomes that we're talking about? What are the best ways to evaluate? Let's build those in. If our current evaluations are not sufficient, we're going to make changes. If the metrics are not achieving the desired goals, we're going to ramp up the metrics. Let me give you an example. If there's a program that requires eligibility redeterminations be done on time for all folks, and our current metric says we're getting 80% done on time, we're going to have to change that to 100%. So we're going to be able to see and measure and ramp up. If we can't achieve our goals, we either change it, in some cases we may have to drop it. The adoption of performance metrics it provides greater transparency and greater accountability. Unified budgeting. I want to describe this very briefly. You'll hear more about this in the coming weeks and months. Some programs, a similar person will be served by agency A, but if they were able to transfer to a program in agency B, we might see that the participant is better off, and it would happen that agency B can claim Medicaid match or some other kind of match. Right now, it's not as easy to shift or let the money follow the person because we're budgeting in silos. We want to have a more unified budgeting strategy so as to enable money to follow the person. And we're going to begin to establish that in this year's upcoming budget through interagency agreements and provisions in the statutes to enable those dollars to follow the person.